I would like to introduce our next speaker, Dr. Angela Lorts. Dr. Lorts is the director of the Ventricular Assist Device Program at Cincinnati Children's Hospital, where she also is the Associate Chief Quality Officer for Outcomes. Dr. Lorts is co-founder and co-director of the Advanced Cardiac Therapies Improving Outcomes Network, which we refer to as ACTION. Dr. Lorts will share her expertise and experience on patient selection for VADs with a Fontan circulation.
Thank you, Christina. And it was so nice to hear from you, Brandon, and hear your story. And you actually did my talk. So hopefully there's still something in here that others will learn from. So I'm going to talk about the systemic ventricular assist device, which is the VAD that Brandon just talked about. We are not going to talk too much today about supporting the other side of the heart, which is the Fontan circulation, but more supporting the ventricular function. So we're going to talk about the Fontan patient that will benefit from an SVAD, patient device selection, review of the data very quickly, and patient referral for advanced cardiac therapies. And thank you for allowing me to speak. This is one of my favorite topics to talk about. I think that there are many Fontans in the future that might need a life-saving device or life-saving therapy. And so trying to figure this out now is the perfect timing for us to figure out the best way to support these patients when needed. So the Fontan patient that may benefit from a SVAD, this picture is Brandon looking at his device, and he had a HeartMate 3, which is one of the continuous flow devices that you may hear about if you're learning more about VADs. And one of the most important things to think about, and when you're deciding if a patient would benefit from a single ventricle VAD or a SVAD or a VAD in general, is where the Fontan circulation is failing. I know Dr. Morales will touch on this as well, so I'll be quick. But when you're talking about circulatory failure in the Fontan, right-sided failure usually presents as plastic bronchitis, PLE, poor ventricular filling because the blood isn't coming from the right side or the Fontan circuit to the ventricle, high pulmonary vascular resistance. Most of those issues will not be fixed by the devices that we're talking about today. But when you're talking about ventricular failure, so that one ventricle that is functioning and pumping the blood to the body, if that ventricle isn't working well, so there's dysfunction or high pressure or not delivering enough blood to the rest of the organs, that may be where a single ventricle VAD like what Brandon had would work. Combined failure is tricky. So combined failure, which is usually what we see when we get referrals, is where there's a right-sided problem, so the pressure is high, and there's also a pump problem. So in this case, we're not always sure, and not every patient would benefit from a ventricular assist device. And this takes a little bit of finessing to figure that out. Combined right and left-sided failure, the questions that we ask to see if a VAD would help: is the pressure high enough in the ventricle that if you lower that pressure in the ventricle, will it help the Fontan flow throughout the circuit? Is the Fontan actually filling the ventricle? The only way the VAD will work is if the blood flow is getting to the VAD. And would increasing the cardiac output even more than it already is improve your end organ dysfunction? So there's a lot that goes into thinking about whether a Fontan patient will benefit from a VAD like Brandon did. And when thinking about this for Brandon, he was really more of the systemic ventricular failure. His ventricle wasn't squeezing well, and it was kind of big, and we call it boggy. Sorry, Brandon, that doesn't sound very nice, but your ventricle was very dysfunctional, and that was why a VAD would work for him. And so then thinking about what the patient and what the device that is right for the patient is, those have to be a good match. So once you think that the patient might benefit from a VAD, what VAD should you select? When we think about pediatric VADs or even adult VADs in the general population, we think of these indications. So decompensated heart failure that's unresponsive to medical management, escalating inotrope support, and end organ dysfunction. So when I relate this to what Brandon and where he was at, he was doing okay for a couple months in the hospital, as he mentioned, waiting for a heart transplant. And then he started to get worse. He started to get bluer. He started needing more drips. And then his liver and his kidneys started to look worse by his lab values. And at that time, we knew he couldn't wait longer just the way he was. And so a ventricular assist device was the answer for him. I think when we think about VAD indications in general, and then we extrapolate this to the Fontan population, it becomes a little bit difficult. And the reason is that some of the contraindications to VAD, Fontan patients just inherently have. So bleeding or clotting disorders, and I bolded these two, and irreversible end organ dysfunction, neurologic deficits, we don't see any different than the other patients, and then social support or non-adherence concerns, which is a rare contraindication. But why I bring this up is that Fontans often have end organ dysfunction, and it's really hard to know when it's irreversible. So that plays into the decision as well. We also know that Fontans have hematologic abnormalities or bleeding or clotting disorders late in their course, and will that affect the VAD? So there's a lot of research left to do regarding this right now. We think that we can usually manage those bleeding and clotting disorders from a Fontan, but that is going into our thought process as we decide on the right patients and the right devices. And I think Fontan VAD timing is very difficult. And Dr. Morales and I were even talking about this before we started this webinar, is that that's one of the biggest things is when is the end organ dysfunction irreversible, or when can we make it better? And you don't want to be too late. So this Mad Hatter quote is kind of fits with this situation, in that you really want to get support to the patient as quickly as possible, and the timing is so important. And then patient selection. So we extrapolate this from the bigger data sets of all patients undergoing VAD, because there's not as many Fontan VADs to learn from. But we do know that the Fontan VADs that we do know about and have written about, and I'll show you that data in a minute, that most of the VAD implants happen when the patients are pretty sick. And we do know that the sicker the patient is, the worse, or the more likely they may not survive after the ventricular assist device. So this once again goes towards the timing being so important to when the device should be implanted. This slide is just showing that in the pediatric world, if you add intermax profiles, which is this kind of lingo that we use in ventricular assist device timing, 1 and 2 are the really sick patients, and more than 85% of the patients that go to VAD implant are really sick. And with that, I just want to show that the sicker the child or patient with congenital heart disease is going into the VAD, the less likely they are to survive. So this plays into this. It's not too important to look at every detail of this, but the sicker patients, which are those in shock, have a 50% survival at 6 months. So the important point of this is the quicker we can decide on a device and the right patient that we can support and either get to transplant or destination therapy, the better the patient will do. I mentioned bridge to transplant, and I know Dr. Lubert and Brandon kind of talked about that, but there's other reasons for implanting a VAD. Some of them pertain to the Fontan, some of them do not. But just as we talk the VAD lingo, important to know that most of the time we're doing the Fontan VADs as a bridge to transplant. Bridge to recovery is less often. Bridge to eligibility and decision is becoming more frequent. So those are the patients that we're not sure if they can get a transplant, but we want to see if we can make their lungs and liver and kidneys better so that they can go on to transplantation. But destination therapy, which I think Dr. Morales will touch on as well, is a really important indication for VAD that we need to be thinking about moving forward. With organs not being just always available, if we have Fontans that are failing more and more, so the numbers of Fontans failing become more frequent, we may not have enough hearts to transplant everybody. And so at that point, we have to start thinking about, are there other opportunities to support these patients? Could we use destination therapy? Can we keep them on VADs for a long time? And what's the quality and quantity of life that they will have? We know in the dilated or the non-congenital population of adults that some of those patients are on VAD for over 10 years and do very well. We know from Brandon's story, he was on his HeartMate 3 for 3 years and did great. And so we know that the long-term support of some of these Fontans is doable. So how do we continue to learn from that patient population experience? When you're thinking about VAD, so we kind of talked about what device are we going to use, what patients are good for VAD. We also think about, are we going to support them short-term or long-term? And this isn't as relevant to this conversation, but kind of just explaining the VAD lingo that might be mentioned in Dr. Morales's talk as well, is there are devices that are for short-term and some that are more durable. The devices available that we think of as pediatric cardiologists are the following. So over on the left here, this is just an example. There's other devices like this, but this is a CentureMag. This is a device that we may use for urgent support, more like ECMO. Then there's these 3 devices in the middle that we could use to support the VAD if the ventricle is failing. This is a Berlin heart, a Heartwear device, and a HeartMate 3. And as the size of the patient increases, we more likely move towards the HeartMate 3. And then if there's multifactorial failure, so where we're having right-sided failure and left-sided failure, then an artificial heart might be an option. The HeartMate 3 is what Brandon had. That device unloaded him very well, but he was big enough for that device, so he was able to get that. And he was the first Fontan with a HeartMate 3 that was published in the literature. When you're choosing a single ventricle VAD, thinking about patient size, and this is more for reference or questions afterwards if more people have questions about whether to use a HeartMate 3 in an inflow or a Heartwear. Really, it depends on the patient size, the chest size, the flow that the patient needs. And as I said, Dr. Morales will get a little bit more into that. And then thinking about, what device can we fit in patients, trending towards using 3D imaging and CT scans to really figure out the best device for the patient, that individual patient. And then once we get a VAD in place and the patient recovers, can we really get them out of the hospital to rehabilitate? So putting a VAD in for a week or an hour isn't probably the best use of resource or making the patient go through a surgery of that sort. But can we get the patient really strong, eating, doing cardiac rehab, making them the best transplant candidate they can become? So you can see Brandon fishing again. That's a common theme. Brandon likes to fish. I think that we have all of these pictures because he likes to send us the pictures of him near the water after he gets home in his house. So he never sends them when he's there because he knows we'll call. He called afterwards. We usually get him at night. So he's had a big day fishing. So we can't call him and say, please get off the slippery rocks. But anyways, so giving him nutrition and physical rehabilitation was so important for Brandon. He went in so sick and came out and did all the rehab he could do. Ate one of his favorite fried bologna, which I didn't know what it was. So I learned that and had a great quality of life. And I think that a transplant status can change. So if you implant a patient as a bridge to decision, you can decide after the patient's, rehabilitated whether transplant's the right thing or is it that we leave them on the device that they're on. So a quick review of the data. This is the action cohort that was just published in JHLT just in January 2021, looking at survival. Survival is not always the most important outcome. It is very important, but adverse events as well. And in the interest of not having a ton of time for this talk, I just focused on this one figure. But 69%, so this is 1 year, and 69% of the Fontans, which was a cohort of 45 patients, survived to transplant at 1 year. 21% passed away. Once again, I'm not going through kind of the details of what those patients were like before they were implanted, and 9% were still alive on device. And what we really hope for these patients that get VADs and Fontans is that their pressures change in their Fontan, and their pressure in their ventricle changes and allows blood to flow. This figure really shows patient by patient, but you can see with this systemic VAD in place in the ventricle, the pressure in the Fontan and the pressure in the ventricle comes down in most of the patients. This is an outlier, but most of the patients, we just don't have great data. One, because the patients, there's not very many of them, and two, we don't always look at their pressures, but this is just an example of what we want to happen. And this did happen for Brandon. I believe Dr. Morales has that slide in his deck, which shows Brandon's pressures decreasing pretty dramatically after surgery. But I think the most important thing, as I said about the Mad Hatter, is it's about timing. And so we don't want to be too late. So patient referral is really important. When we're starting to think about a VAD maybe being in a patient's future, getting the heart failure team or advanced cardiac therapies team involved early and partnering with the congenital physicians is super important. We know there's a lot of challenges. As I said in my talk, we don't completely always know who will benefit from a VAD. We're pretty sure that for having a high pressure in that ventricle, having dysfunction, those patients will benefit. We don't know exactly the timing, but we do know that earlier is better and later has a decreased survival. We don't know for sure if destination therapy with a VAD is going to improve quality and quantity of life. But what we've seen so far in the patients that have had VADs, and we have tried to bridge them out, that they do pretty well. And Brandon's a perfect example of 3 years doing great with his VAD and fishing and scaring us all. I don't think he was admitted to the hospital more than a couple times during that stay. And it was always when I was on, he'll tell you. Barriers to referral to advanced care, I think, is one of the biggest challenges. We do hear a lot from families when we've asked these questions, especially through the Action Network, is they really don't want to meet a new team when the health is declining. They would love the teams to work together. And I thought this was a great quote, because I think this would be ideal, is that if, for example, Adam and I could work together in a heart failure clinic, which we are establishing, it works really nicely because we can easily go back and forth. So I will see a patient and say, Adam, I don't think that this patient's ready for advanced therapies. And it goes back to Adam, and we were able to touch base with each other. So I do think that will be an ideal situation in the future. It's just how to get there. This action referral document is online, or we can send it to you if anyone's interested, but this is the VAD perspective or heart failure perspective of when a patient should be referred for advanced therapies. Some people would think this was too early. The VAD heart failure team thinks that we would really like to see these patients at this time. That doesn't mean they need a VAD or a transplant, but it means that we should start to partner. And there's still a lot of questions that we often get that we need to answer. And Action, which is the VAD Learning Network, is really trying to come up with the best answers to these questions. Technical optimization, Dr. Morales will talk about the surgical technical aspects, but should a Fontan fenestration be open or closed, and which patients benefit from a fenestration? Do we need to modify our postoperative care protocols, which we in Action think yes, compared to our dilated or other non-congenital kids? How long can we go without anticoagulation in those Fontans that bleed? We think we can go a while now with the newer pumps, so that will change the field. Can the pumps run on with a high cardiac output that's necessary for a Fontan? The newest pumps, yes, they can supply a huge amount of blood flow to a Fontan that needs it. Can we optimize care to achieve the same outcomes as the dilated cardiomyopathy patients? And this is the goal that Action has. How do we achieve very similar outcomes to our other patients? The takeaways from this slide deck is hopefully that timing for referral is really important, and hopefully that to me, I think is maybe the most important, is how can we work together to make this better? There's a lot to learn about patient and device selection. We can only learn together. Longer support may lead to better transplant candidacy. Can we make the end organs better? Can we make the patient stronger? Can we give good nutrition, get them out fishing so that when they are transplanted, they're the best they can be?